Honey?
Good afternoon. I am honored to be here today, and I am delighted to talk to you about cardiac resynchronization therapy in women. Now, as you well know, heart failure affects 5.3 million Americans, and about half of those are women. It contributes to 35% of the total female cardiovascular disease mortality, but in spite of that fact, it is a poorly recognized syndrome in women. If we look at the most recent randomized clinical trials of medical therapy in heart failure, what we can see are that only 20% of those enrolled in these studies are women. So women are severely and significantly underrepresented in these clinical trials. Although the incidence is higher in men for heart failure, we know that the prevalence is about the same in all age groups until women reach about 80 years old, and then their survival rate is better than men. From 1979 to 2004, the hospital admissions for heart failure, which is really a marker for advanced heart failure, was consistently higher in women across this time than in men. And if we look at the Medicare database for those patients who were admitted with a diagnosis of heart failure in the years 2002 and 2004, what we can see is that women across the board had a higher consistent rate of admission, 54% women versus 46% men. Now, despite a slightly lower prevalence of heart failure during this period of time in women, the mortality was significantly higher, 61%. And during this period also, cardiac resynchronization therapy had become a significant part of the management of those patients with advanced heart failure. Those sick patients with an EF of less than 35%, a wide QRS 120 milliseconds or greater, functional class 3 or ambulatory class 4 heart failure, and appropriate medical therapy. But if we go back to that same Medicare database through those years, although the rate of implant, and if you can see this on the total, you can see that the rate of CRT implant consistently was higher, but women consistently, again, through this period of time, had a lower utilization of CRT. So 25% of the women received the device and 75% of the men did. So we know during that period of time, women had more heart failure hospitalizations, but they received fewer CRT devices. So why is that? Maybe women don't respond to CRT therapy. Well, an observational study by Bleecker was done to look at the gender difference in the response to CRT. And what he showed was really there was no significant difference between men and women. There was no gender disparity. Men responded about 80% of the time and women about 76% of the time. But look at the number of women that were enrolled in that trial, only 36. So let's look at the major randomized clinical trials where the numbers are slightly larger. The Miracle trial enrolled a total of 453 patients, and 144 of those were women. They were randomized either to CRT or the control group, which was on optimal medical therapy, and pacing was programmed off. And when we look at the difference in baseline characteristics, what we see are the men were older and they had a higher incidence of ischemic heart disease. But when we look at the study's endpoint, what we see are the women, as illustrated here in the dashed lines, that received cardiac resynchronization therapy had a statistically significant decrease in first-time heart failure admission or death in comparison with the control group. And there was actually no difference among men. The companion trial, which I'm sure all of you are familiar with, enrolled 299 women, and these patients had, again, low EF, heart failure, and a wide QRS. And they were randomized to 1 of 3 groups: optimal medical therapy, or OPT and a CRT pacemaker, or OPT and a CRT defibrillator. And what the study showed was there was actually a survival benefit for women who had CRT therapy. The CARE-HF study also enrolled 215 women with basically the same criteria. And that study showed that there was a trend that CRT was preferable to medical therapy alone in women for the combined endpoints. The largest trial to date, the largest device trial to date that enrolled women is the MADED CRT trial. And the inclusion criteria was for those patients with heart failure, class 1 or class 2 and ischemic cardiomyopathy, or class 2 and non-ischemic cardiomyopathy, a left ventricular ejection fraction of less than 30%, a wide QRS, a little bit wider than the other clinical trials, 130 milliseconds or greater. All these candidates had the appropriate indications and approved indications for ICD therapy, but the hypothesis of this trial was in those patients that are asymptomatic or minimally symptomatic, can the addition of CRT to the defibrillator actually prevent heart failure progression and decrease the morbidity and the mortality associated with this patient population. So in MADED CRT, patients were randomly assigned to a 3:2 ratio to receive either a CRT-D or an ICD. A total of 1,820 patients were enrolled, and look at the number of women, 453 women. Now, don't get confused by the percentage. Only 25% of the study was women, and if you look at the Miracle trial, 32% of those are women, but the Miracle trial only had 144 women. So the largest device trial with the largest number of women in this clinical trial. And the results are that CRT-D was associated with a 34% reduction in death or heart failure in minimally symptomatic patients with either substrate. And there was a 41% reduction in heart failure events. And women had CRT-D was more effective in women than men, and in patients with a wider than narrower QRS complex. So if you look at the 10 pre-specified subgroups, what you can see is that they all benefited from CRT, but by and large, the group that had, or the group that had the largest benefit was the female population. The males had a good benefit, but the females had a great benefit. So let's look at the sub-study analysis for some of the answers to why this could possibly happen. If we look at the baseline findings, what we can see is that the female patients were more likely to have non-ischemic cardiomyopathy, left bundle branch block, and better renal function than men. There was really no major difference in the heart structure based on echo parameters, and all patients were very well treated with medical therapy with some significant differences in utilization between men and women. But when we look at the study endpoints and compare the outcomes between men and women, what we see for all 3 outcomes in total population, death or heart failure alone, or death at any time, women achieved a better result, statistically significant, over men, and the difference was between the sexes. They also achieved better results for 2 out of 3 incomes in the non-ischemic cardiomyopathy. When we look at the changes in the median echo parameters between baseline and 1-year follow-up, what we see are that there were greater improvements with those patients that had CRTD. The men in the green and the females in the white. The left ventricular volumes actually decreased substantially, but women had a greater improvement, as illustrated here, than the men did. And if we look at the change in left ventricular ejection fraction at this time, what we can see is a significant increase in EF in the CRT group, with about 11 units increase. So an ejection fraction going from 25% to 36%, really significant, preventing heart failure. To me, this is the most striking slide of my deck. What you can see over time was the probability of heart failure or death was much lower, statistically significant, for those females who had CRTD. But look at the curve for those females who received an ICD. They had the highest mortality in heart failure events. So what this is telling me in my mind is that these patients didn't die an arrhythmic death or sudden cardiac death. They died from heart failure or pump failure. So the sub-study has revealed that women are more likely to have non-ischemic cardiomyopathy than men, and they are more likely to have a left bundle branch block than men. They had a 70% relative risk reduction in heart failure in women and a 69% relative risk reduction in death or heart failure. The men had a good benefit, but the women had a great benefit. So, females in mated CRT received a striking benefit from this therapy with a significant reduction in all-cause mortality, as well as heart failure, death, and death endpoint. The mortality reduction was especially prominent in women with a QRS complex that was greater than 150 milliseconds and in women with a left bundle branch block. So when Boston Scientific was working with the FDA to try to receive approval for this modality of therapy for Class 1 and Class 2 patients, the FDA asked for a longer follow-up period. And during that particular time, as you can see here, we have an extended follow-up period. The females with CRT in the yellow continued to show a benefit with this therapy, but they also demonstrated more than twice the benefit than the male populations. And an incidental finding was that these women had a higher incidence of left bundle branch block. Remember I said 87%? Well, a sub-analysis or post-hoc analysis was done according to bundle branch block. And what you can see here is that left bundle branch block was associated with substantially greater improvement across all endpoints in comparison with the entire study population. And look at the non-left bundle branch block, which includes an IVCD and a right bundle branch block. They actually had no benefit from CRT therapy, or minimal. Sorry, I'm on the wrong slide. Minimal benefit. So left bundle branch block, significant benefit. Non-left bundle branch block, no benefit. So in summary, according to the updated results, in asymptomatic or mild heart failure patients with a wide QRS, left ventricular dysfunction, and left bundle branch block on stable optimal medical therapy, CRTD as compared to ICD was significantly associated with, number one, a reduction of 57% in the risk of a composite of all-cause mortality or heart failure events. And this was driven by a reduction of 35% in the risk of death and a reduction of 63% in the risk of heart failure events. Reduction of 43% in the risk of recurrent heart failure events is the second summary update. So this is an acceptable safety profile, and the FDA did approve indications for these patients in September of 2010. Thank you for your attention.